objective, that is to make predictions about emergent properties of a system. That system could be a cell or patient, and I try to achieve that by utilizing a set of bio data, typically omics data, and in recent years, medical data. Now, because I'm doing computational, in my lab, the research topics are rather broad, synthetic biology and medicine area, but today I like to pay particular attention to cancer metabolism. So today I will be putting more focus on predicting what is called oncometabolite candidates. Then I would like to talk about a little more extended application study, that is to predict drug targets for high-risk cancer patients. Now, cancer, I'm not a cancer biologist, obviously, but just to have the motivation, cancer cells or tumor cells, they arise as a result of many factors in and outside of the cell. Now, the consequence is very complex. One of the systems that gets reprogrammed during this cancer development will be metabolism that you see in the middle with the orange arrow. For metabolism, we have a lot to talk about, but within cancer metabolism, I like to talk about oncometabolites. Now, onco means cancer. So just briefly, oncometabolites, these are the ones that are uniquely found in tumor cells, or metabolites with the elevated tumor cells in comparison with the normal cells. Now, such identifying oncometabolites are important because they can serve as diagnostic biomarkers, or we can use them as a drug target to come up with effective anti-cancer drugs, as you see in a later slide. Now, it's been around 10 years for this study oncometabolites in the cancer community. And so far, 3 oncometabolites have been established. The D2-hydroxyglutaric succinate fumarate. These are the 3 only well-established oncometabolites. They have 2 common denominators, 2 common features. One is that they are all associated with the epigenetic dysregulation, which means they are somehow involved in cancer development. The other common feature would be that now these are metabolites, which means that enzymes are responsible for generating these oncometabolites. So all these responsible enzymes, they have a gain-of-function mutations. So these are 2 common factors. By the way, as to the motivation of studying oncometabolites, I think this is a very good example of why you have to study oncometabolites. Ivosidenib, that's a FDA-approved drug back in 2018. It's an inhibitor that works on isocyclic dehydrogenase, which is highly associated with the generation of the oncometabolites, as you see here. So that's one really nice, successful example of exploring oncometabolites. Now, speaking of tumor cells again, now tumor cells, they are known to be associated with the tens of thousands of mutations or thousands of mutations. So there are a lot of mutations, but then so far we've come up with only 3 oncometabolites, which comes to be as a mystery. So shouldn't there be more metabolites that would be associated with the mutations? So that was the very motivation of developing prediction platform tool that generates oncometabolite candidates. Long story short, so we come up with a computational platform that predicts oncometabolite candidates as an output. Now, input data, we require 2 things. One is the mutation data from cancer patients, and the other one is the RNA sequencing data. As I will elaborate in a later slide, we can actually build cancer patient-specific metabolic model by using patient-specific RNA sequencing data. So these are the 2 input data that we need to predict oncometabolite candidates. So then, for those of you who may not be familiar with the metabolic model, again, this is a type of mechanistic model. This is more like metabolic network model. So it's a model that contains information on entire metabolic genes that are available in a cell. its output is very straightforward. Let's say this is a cell boundary or cell membrane. Each arrow indicates biochemical reaction that is catalyzed by enzyme. So then what the metabolic model does is it allows us to predict the reaction rates or flux values for each reaction. So using this technology, we can calculate the metabolic phenotypes by looking at the predicted flux values for each of the biochemical reactions. The building metabolic model starting point is always genome data. So that means if genome data is available, we can build metabolic models in a pretty straightforward manner. So far, most of the model organisms that are known to be important in medicine and biotech, the metabolic models are available, high quality, including the yeast strains that we heard about earlier. So we have several different versions of high quality metabolic models in the community. Now, this modeling technology initially started from, initially they were applied to microbial metabolism, but the metabolism is a subsystem that is very conserved across organisms. So at some point, people start thinking, hey, why shouldn't we apply this metabolic modeling to human diseases? So now we are witnessing increasing cases of applying such metabolic modeling technology to human disease systems. Just giving you a brief history of human metabolic model. Initial version, we think to be the legacy model that was built back in 2007 at UC San Diego. Then over the years, it's got updated through the international consortium efforts. So we so far have a pretty good quality metabolic models for human system, and this is what we have used in my lab to come up with the oncometabolic candidate predicting computational platform. Now, I said that metabolic model, it allows us to predict flux values for the entire biochemical reactions. Another important thing is that we can build patient-specific model as long as we have the RNA sequencing data. And as I mentioned earlier, this patient-specific or person-specific model is one important input data for the prediction platform. There are some algorithms that we need to optimize, but yes. So to develop the oncometabolic candidate predicting platform, we first needed to build a good number of patient-specific models to ensure the statistical power. So we obtained RNA sequencing data from these two sources, TCGA and PCOM, and we were able to develop more than 1,000 patient-specific models across more than 20 cancer types. And we see a nice clustering of the patient-specific models depending on their cancer type, which means these patient-specific models very much will reflect the unique metabolic properties of each cancer type. Because we have to generate multiple metabolic models, we have to make sure that quality, but there's also a nice platform also coming from the international collaboration that gives you the scores, how good the resulting model is. So all the models that we developed, they go through this QC test. So this is a little more detailed scheme of what I showed you earlier, predicting oncometabolic candidates. I try to keep it as simple as possible. It largely consists of 4 steps. The first step is about predicting the importance of each metabolite in the cell. Now, within the cell, typically any single cell is known to have like thousands of metabolites. Now, we can calculate the relative biological importance of that metabolite through a simulation method that's called Fluxum, but let's put that aside for a moment. The second step is quite critical. Now, we associate that predicted biological importance of the metabolite with the mutation, presence of mutation across the gene. Now, this is coming from statistical tests, but this is a step where we get to pair each metabolite with specific gene mutation. Third and fourth step, this is more like removing unrelated pathways in genes. Let's say there's a metabolite A. Now, there could be more than one metabolic pathway that can contribute to the biosynthesis of that metabolite. Likewise, there could be more than genes that can contribute to the biosynthesis of the metabolite. So now we want to remove such pathways and genes that are not much have nothing to do with the overall metabolite candidate. So at the end, what we get is metabolite gene pathway sets. I said oncometabolite candidates, but that means we predict metabolites that are also associated, that are paired with the specific gene mutations and also associated with the specific metabolic pathways. A little technical stuff, but initially the idea of flotsam that was developed quite a while ago for bacterial system, but then we decided to apply this concept to cancer metabolism. We had to make sure that this flotsam values that we can calculate by using metabolic models, they have they are capable of distinguishing normal and cancer samples. There are some poor cases, but most of the time we were happy with the capacity of flotsam values for this discriminating power. Now, once the predictions are made, then we have to obviously validate the predicted oncometabolite candidates. So I was very much grateful for these doctors at a hospital. We were able to obtain samples for these two different types of cancers, blood cancer and kidney cancer. From the samples, we obtained 3 different omics data. Now, what we see here, the red dots, these are the predicted oncometabolite candidates, and they appear to have pretty good discriminative power compared with other metabolites that were not predicted as oncometabolite candidates. Now, in other words, they have a drastically different concentrations inside the cell depending on the presence or absence of mutation in each of these genes. And similar observation was made for the samples coming from the kidney cancer patients. Now then, now there's a great amount of literature available on cancer metabolism. So we try to validate the predictions from a little different angle. Now first, similar number of samples, but then different number of oncometabolite candidates, which means that the number of oncometabolite candidates that we get to predict, that's not simply affected by sample size of each cancer type, which is a good thing. Now, when it comes to cancer metabolism, 3 pathways are known to be very important. These are kind of related: amino acid, carbohydrate, and the lipid metabolism. So they are all associated with the energy generation within cancer cells. They get rewired during cancer development. So that's a kind of good thing. And if we sort the genes that were predicted to be associated with oncometabolite candidates, these are the top 10 genes. We see that the genes, very well known cancer driver genes, these were predicted to be associated with oncometabolite candidates. So overall, the predictions appear to be consistent with what has been reported in the literature. Finally, we had a more detailed focus on brain cancer, glioma. So we gathered papers that report make reports on mutated gene metabolite pathway for this particular cancer type, and overall, through the comparison with our predictions, we were able to see around 70% consistency. Now, the remaining 30%, that's something, well, they would be false positives. or that's something that we need to explore in coming future. So this is the full comprehensive list of the predictions that we made using the platform. So we predicted oncometabolite candidates across 18 cancer types. Now, this is not a resource that is expected to be used in a clinical setting, but rather I think this to be more like a resource for the fundamental studies. So in the future, if anybody wants to study oncometabolites, particular oncometabolites, we hope that this resource serves as a sort of reference information. Second topic is about predicting drug targets for high-risk cancer patients. Looks complicated. I'll again try to make it very simple. Now, the motivation is that even for the people suffering the same cancer type, let's say bladder cancer, some people show good prognosis, which means they have the extended life span. Others show poor prognosis, which means that they may die at some point. So that motivate us to come up with one question. Now, these are the people suffering the same cancer type, but they show different prognosis, which means somehow we have to come up with different drug targets depending on the risk level of the cancer patients suffering the same cancer type. So that was a valid motivation. So for the high-risk cancer patients, there should be another distinct set of drug targets. So flow value, which I mentioned earlier, which again indicates the relative biological importance of a metabolite. Now we combined that with the medical data, that is survival data of patients. And what we did was we tried to establish what is called risk score. Before that, we try to first select metabolites that can work as the markers for a patient's prognosis. Now, by using selected prognostic metabolites, we established risk score. Now, the final step, what we did was we can actually do the knockout or knockdown simulation by using the metabolic model. So what we did was we predicted drug targets through via knockdown simulation, and these knockdown targets are supposed to reduce the risk score that we established in the second step. So long story short, we came up with 12 regression targets. By the way, we worked on this platform particularly for the bladder cancer patients. Do I have the terms? So this is a risk score that I mentioned, which we established in the step 2. So these are the prognostic metabolites. So these are the metabolites appear to be somehow associated with the patient's prognosis. So we used this information to establish the risk score. And I said that in the step 3, we predict knockdown targets. So we compare with the reference risk score, which is coming from the cancer cell without any perturbation, and then we come up with knockdown targets, which we hope gets reduced as a result of this perturbation, and then we calculate the risk score and come up with final drug targets that could be effective for the high-risk cancer patients. Once we have the drug target candidates, of course they have to be validated in vitro and in vivo. So this is, I think, a typical routine validation process. We selected cancer cell lines, we selected potential inhibitors, make sure that they are effective for the selected cancer targets. So these are the targets that we predicted using the platform. These are the associated genes, and this is the list of in vitro validation outcomes. Pretty personally think a decent success rate. Then finally, I'm not showing here, but then we moved on to in vivo validation. We were able to observe the reduced tumor size as a result of applying the selected inhibitors coming from the in vitro validation. We hope that we release the data early this summer, but that's been a pretty fun project. So, a few things I'd love to discuss. We often talk about big data. That's always a big challenge, because when it comes to a specific problem, it's not a big data, it's a small data. We are always short of data. So it's both a challenge and opportunity. And what are the models we get to use? We have to go through the rigorous systematic validation that's ours. And finally, I talked about today metabolic model, which is a mechanistic model. Now, from an engineering perspective, we don't always have to stick with AI technologies. I think it really depends on problem definition and also the quality and quantity of the data available. And by considering these multiple factors, I think we have to carefully select what computational model to use. And I say that still mechanistic models can be effective, and rather be using multiple different types of multi-models. They can be complementary to one another. Each model has its own inherent limitation, but by using multiple models, we can sort of mitigate the limitations of each of the models that we use. The achievements that I talked about today, these two graduates from my lab who are now at Harvard Med School, they have made substantial contribution. I was very much fortunate enough to work with them. And then, thank you very much for your kind attention.
Does anyone have any questions?
What type of model was made to make a metabolic model? And B, ingredient and
Very good question. It's a set of linear equations. And it's composed of thousands of equations. So it's a huge matrix system. Initially, we modeled with the ODE, but then by using a certain assumption, we convert that into a linear system. So basically, it's a linear system. That's a one huge matrix problem.
Make the equation by the transcriptome data. You use
So building that stoichiometric model, the matrix, a set of linear equations that's coming from genome data, genome annotation data. Within genome data, all the genes are annotated, right? Then we know what genes are metabolic genes. So we simply take those information. Of course, we have to associate each metabolic gene with the biochemical reaction information. That's another story. But starting point is, if you have only one genome data, then you can build one single metabolic model. Now, RNA-seq data, that's for the human system or mammalian system, because the cells in the brain, chest, leg, they have the same genome content, but they have different expression profiles. So we use RNA-seq data coming from a specific cell to create the cell-specific metabolic model. So the genome data, RNA-seq data, they have different purposes when creating the metabolic model.
Thank you.
So the cancer, the tumors that you studied were AML and venous carcinoma, and I think those types of tumors are kind of well established to be connected to metabolism dysregulation. So I was curious if you were studying uncommon metabolites of other tumors, perhaps. So,
Sorry, I missed the first part. What was that?
so like RCC and AML is well known to be connected with metabolism dysregulation. So, are there other cancers whose oncometabolites you're studying?
Oh yes. So I don't remember the full list, but if you remember the record one slide in the middle right before the second chapter. So we released a full list of oncometabolites across 18 cancer types. So I believe we get to see the more diverse cancer types in that list. So I remember all the cancer types. And also the second chapter, the second part, that was done for the bladder cancer. So 강화만. So yeah, but yeah, that's my answer.